Okay, good morning and assalamu alaikum. Welcome back to pathology lectures on endocrine reproductive block. Today's topic is thyroid gland. Learning outcomes. The session will be, if you see there are many learning outcomes. Mainly, we are going to start with hyperthyroidism and hypothyroidism, the clinical manifestations of these and the causes. Then we go specific diseases in terms of thyroiditis, different types of inflammation in thyroid, and then we talk about goiters, specifically multinodular goiter, which is very common in especially some part of the world where there is iodine deficiency is significant in the diet. And then lastly, the tumors of thyroid gland. This is very important, benign and malignant tumors. This is one of the favorite topics, and specifically in OSPs. So we have a practical next Wednesday on this. As I mentioned, we are going to do the practical theoretical aspect recording after this session immediately. And during the practicals, we do more on the slides. Okay, so to start with, you already know about the thyroid gland anatomy and physiology. You have done your lectures. So it is basically thyroid gland has two lobes, which is laterally at the front of nerve connecting both the lobes is isthmus, and which is located just below the larynx. Microscopically, thyroid gland is lined by thyroid follicles, cuboidal epithelium. At times it can become low columnar, filled with thyroglobulin. Basically, the function of these thyroid gland, thyroid follicle, thyroid epithelial cells convert thyroglobulin into thyroxine and T3, T4, you can tell. Both are functional hormone, which is released in the blood and has multiple functions all over the body. The physiology is very clear. Thyroid gland, we have to keep in mind, has other cells also, which called parafollicular cells, C cells, which synthesize calcitonin. At the same time, back of thyroid, you can find 4 small, tiny parathyroid glands, which secretes parathyroid hormone also. So thyroid disorders, which we are, as I mentioned, focusing today, will be mainly to keep in mind Graves' disease. Thyroiditis is Hashimoto's thyroiditis is more important. Another form also diffuse and multinodular goiter and neoplasms of the thyroid gland. So okay, so the point to start with is hyperthyroidism. So, or it's also called as thyrotoxicosis. The word itself is giving an idea of toxic state due to thyroid function or thyroid hormone. So you already know thyroid hormone is basically a metabolism regulating hormone. So that keeps your basal metabolic rate at a required set point. And so the thyroid hormone is a catabolic hormone. Is that true? Anyone? Thyroid hormone is anabolic hormone or catabolic hormone? Think about it. And I am telling it is catabolic. So why catabolic? You need to have your answer in the mind. This physiology should be in the back of mind. That explains all the features. So thyrotoxicosis is a hypermetabolic state caused by elevated circulating level of thyroid hormone, that is T3 and T4, which can be sourced from thyroid gland or at times extra thyroid glands. That can be possible in neoplasms, stroma ovary. This is a condition we are going to talk very soon in the coming weeks, in the ovarian disorders. So the causes for hyperthyroidism, this is once again an important point for the exam point of view. Favorite SCQ question: diffuse toxic hyperplasia, Graves' disease. This is a condition which is autoimmune. Very interestingly, you can think now, I'm telling a disease which is autoimmune, which many times you think autoimmune antibody destroys. But here the hormone level is going up. What's that? How's that? Very interesting. Autoimmune disease causing increase in the levels of hormone. Another important is a multinodular goiter. Goiter means swelling of thyroid gland. There is multiple nodule. It's non-neoplastic, at times non-inflammatory also. But it is like a hyperfunctioning. But some nodules become toxic, produce a lot of hormones, and then it goes into hyperthyroid state. Another is adenomas. Adenoma is a benign tumor, but when it becomes, we call functional tumors which produce hormones, and that is toxic adenoma. And in neonates, it happens when mothers are suffering from any hyperthyroid state, specifically in Graves' disease, they may end up in hyperthyroidism. And then secondary hyperthyroidism can be because of TH secreting pituitary adenomas. We talk about this already, pituitary adenomas, in our first lecture. So to summarize here, you can find the states, disorder associated with thyrotoxicosis. So the primary and secondary I have already mentioned here. So one of the important is also iodine induced, which is sometimes excess of iodine, or there is some metabolic disorder, genetic inborn errors of metabolism with iodine, that lead to hyperthyroid state. But always keep in mind, because it's a other condition not associated with hyperthyroidism, but there can be thyrotoxicosis. So these are the other causes: decurrent thyroiditis, which will have a painful situation. Just to keep in mind, subacute lymphocytic thyroiditis, where you see thyrotoxic state possible. Stoma ovary, as I mentioned, ovarian teratomas with ectopic thyroid gland, and factitious thyrotoxicosis, exogenous thyroxine intake. Last one is very interesting. Last one is all these are thyrotoxicosis state, which some are excess thyroid hormone in the blood, some are not, the other part. But fictitious is when, and in some society, the thyrotoxic is constantly eating the thyroid gland from the animal source. That can be something different. So what is the clinical presentation? When there is high level of T3, T4, overactivity of the sympathetic nervous systems happens, association with the high level of thyroid, metabolic states, hypermetabolic state. The clinical presentation of hypermetabolic state, heat intolerance. So these people, very often you come across, okay, I remember, and in general, if you think about the thyroid disorders are more common in females, okay, it runs in families. So maternal or paternal origin also. So I remember, I had one cousin in my childhood, early, like my teens. There is a winter, winter will be temperature below 15 or less in my place. And she used to fight with me on the fan, on the coolers. Then I used to tell, what's wrong with you? But that time, that was not, at that time, maybe she had high, later she was diagnosed with thyroid disorders, subclinical, and then in subclinical state. My point is, some people may have these in early presentations. So they may have heat intolerance, little warm also, they start sweating, their hand looks sweaty, the feet look sweaty, and they lose weight, increase appetite. Yesterday I mentioned in the lecture for diabetes, differential diagnosis, weight loss despite increased appetite, thyrotoxicosis or hyperthyroidism. Another is diabetes mellitus. especially type 1. Tachycardia and palpitation is a sign of hypermetabolic activities, increased cardiac activity. Arrhythmias, particularly atrial fibrillation, congestive heart failures, are more common in these people because of all this. They may have enlarged thyroid gland because thyroid gland is functioning, producing more hormone because any reason. And they may have exophthalmos, a wide staring eyes gaze. So very interestingly, if you look this picture, okay, and what is the normal eyeball? The lower eyelid will just touch the lower part of the cornea. The upper eyelid will cover 1 or 2 millimeters of the upper end of the cornea. In case of exophthalmos, we see in thyrotoxicosis, specifically in Graves' disease, you see the lower eyelid corneal margin goes up. You can see the sclera below. This one is what initial presentation. You can see some swelling here. Lower eyelid is seen, but later you can see both upper and lower. The eyeball is pulled forward. So wide staring gaze and lid lag. When you ask them to close the eyes or look down, the lid normally the lid should follow. You can try when you're looking down. Somebody, you can see the lid is coming with them, but there is a lacking because they cannot do that because of the protrusion. Sympathetic overstimulation of levator palpebral superis. There is a muscle which manage your lid function. So that is because of sympathetic overactivity. So what's more in hyperthyroidism is a condition that occurs due to excessive production of thyroid hormone. And okay, what is the difference here? Why this slide is okay? We are on the track. Just this is to think about what is the difference of these two terms. Both are same, but hyperthyroidism is a condition that occurs due to excessive production of thyroid hormone by the thyroid gland, but thyrotoxicosis is a condition that occurs due to excess thyroid hormone of any cause. Therefore, it includes hyperthyroidism, but you have seen the causes here. No hyperthyroidism, but toxic state is still there of thyroid gland. Symptoms are there. That is, we keep in thyrotoxicosis. Next important clinical presentation is tremor. Tremor is fine and involuntary movements of the limbs. Overactivity of sympathetic nervous system is the cause. GI hypermobilities, patient presents with diarrhea. Always, okay, you keep these in mind. Heat intolerance, palpitations, diarrhea, tremors. In hypothyroidism, it will go the other way. So increase osteoporotic activities, thyroid storm. This is a very life-threatening condition. We talk about apathetic hyperthyroidism. These two we'll see some more later. Thyroid storm, a patient with underlying Graves' disease, acute elevation of catecholamine levels. It happens when during surgery, cessation of antithyroid medication, or any form of stress. So basically, these patients will have high catecholamine levels, a medical emergency. Significant number of patients, of untreated patient, dies of cardiac arrhythmia. So this can happen in hypothyroid state because of sympathetic overstimulation by increased elevation levels of catecholamines. Another important clinical presentation of this hyperthyroid state is pretibial mixed edema. Mixed edema is a feature of hypo, but this is a misnomer. You can tell it's basically a dermatopathy of hyperthyroidism, skin changes, which thickening of dermis due to deposition of glucosamine, glycan, and lymphocytic infiltration. Sometimes it can go too bad. You can see here is early. This is a very classic way you may find in some, especially over the years of hyperthyroid state. So how to diagnose? Very simple. It's the classic clinical features, what we have discussed. Lab findings of high thyroid levels. The best test can be serum TSH level, because It's a hormone that regulates the thyroid secretion by hormone secreted by pituitary. So if there is subclinical state of hyperthyroidism, also TSH level will be low because of negative feedback mechanism. Presence of low THS, the most useful single screening test for any of the thyroid disorders, hormonal functional disorders. So confirm with measurement of free T4 levels. That's confirmed. So Graves' disease. Now, Graves' disease, most common cause of endogenous hyperthyroidism. So most common in females in younger age groups. In classically present with three important clinical presentations: hyperthyroidism, diffuse hyperfunctioning enlargement of thyroid. So thyroid gland is enlarged. Ophthalmopathy, we call exophthalmos, what you can see in these females. Lastly, dermatopathy, pre-tibial mixed edemas, which we just discussed about that. Three important triad of Graves' disease. Next time you have to think of. It's a clinical diagnosis is by hyperthyroidism, ophthalmopathy, and dermatopathies. So Graves' disease is autoimmune disease. What it means, the immune system is producing, not here every time we can consider antibodies, but the antibody acts as the autoantigen that stimulates the TSH receptors on a thyroid gland. So basically, when we talk autoimmune disease, the immune system, either cellular or humoral immunity, destroy the glands by producing antibodies, or the cells like T cells will cause injury to the tissue or cells of human body. But what here is the breakdown of self-tolerance by thyroid autoantigen, mostly TSH against the TSH. So these antigens produced by our immunity in the form of antibodies or a protein, you can tell, go and stimulate TSH receptors or thyroid pyroxone. Antibodies are for these, or thyroglobulin. So thyroid stimulating immunoglobulins mimic TSH. Thyroid growth stimulating immunoglobulins, thyroid causes thyroid enlargement. TSH binding inhibitors, immunoglobulins, which inhibit TSH bindings but stimulated by other way. So these are the antibodies. You can tell antibodies, but think about the function is in stimulation side. So produced by our own immune cells. So this can be your SAQ questions, name to autoimmune antibodies seen in Graves' disease. So very important, Graves' ophthalmopathy is very detailed pathogenesis is given here. Infiltration of retroorbital space by T cells because of the immune stimulation, and that cause inflammation, edema, swelling of extraocular muscles. But over the time, there is, because of inflammation, there is accumulation of extracellular matrix component, hyaluronic acid and chondroitin sulfate deposition that makes the ophthalmopathy, the protrusion of the eyes, the exophthalmos more permanent. Like edema, when resolved, the things can go back, but over the time, extracellular matrix component like hyaluronic acid and chondroitin sulfate start depositing there. And further, there is, I'm telling about this soft tissue in the eyeball, around the eyeball, there around the muscles, there you see deposition of extracellular matrix and development of fat. The eyeball, that's why display forward and function of extraocular muscle is disrupted. That's why they have protruded eye. How you clinically identified, I just mentioned that. There is the pictures. No. Okay. So this is the picture. You can see the lower margins and upper margins are much away and scleras are seen there. And very interestingly, clinically, if you, this picture, we check, normally the upper margins of the bone just at your edge of the eyebrows, usually the eyeball will be well inside, but in exophthalmos, If you keep a scale, the eyeball, you can see it's protruded forward. That's how clinically we do that. You will learn it in your clinical skills. So patients are at increased risk, Graves' disease and autoimmune disease. So they are more prone for other autoimmune disease like any other autoimmune conditions you have learned. So they can have SLEs, pernicious anemia, type 1 diabetes, mellitus, or Addison's disease. What is Addison's disease? Anyone? What is Addison's disease? Come on.
Decreased adrenal function.
It increase adrenal function or decrease?
No, decreased.
Decrease, very good. Decrease adrenal function, and mainly it is cortisol levels are low. So you are going to do you're doing this, finding your PBL, first PBL, very vague case, vague clinical presentations, and definitely you'll have differentials. One of the differentials is Addison's disease. So we'll see that in the next lecture, next week. So morphology of the Graves' disease. You can see the Graves' disease, it's really grave, deadly at times. So gross is important, not only for your theory, but OSPE also, diffuse enlargement of thyroid gland. You can see the gland is huge and large. Better to see, put any pictures. Please see the clinical pictures of how the neck will look in the, I'll make sure next time I'll put that, how I'm missing them. So thyroid gland is enlarged. This is too huge for a thyroid gland. And usually it is smooth, soft capsulated, capsule is intact. Microscopically, very interesting is follicular epitheliums become more functionally active. That makes them tall, columnar, and crowded. Crowded is become, they start becoming folded like a papillae. Presence of papillae in any tissues in the glands suggests they are more proliferating. Small papillae are seen here into the follicular lumens. That means the function, and collide within the lumen is pale with scallop margin. Scallop margin is very interesting. They are scooping out the colloid because they are hyperfunctioning. They are taking more. The rate of scooping out is more than the rate of production in the follicle. That's why scalloping is a very classic presentation. Apart from that, because it's in autoimmune inflammatory condition, so you will see a lot of lymphocytic infiltration or germinal centers. Germinal centers are not that prominent in Graves' disease than Hashimoto's thyroiditis. Please remember that, because after this I'll talk about Hashimoto's thyroiditis, and key findings you have to talk about: tall columnar cells, papillary proliferations, scallopings, and lymphoid infiltrates with sometimes germinal centers. Clinical features is very important in this diagnosis. You will see Hashimoto's may show similar features, but their lymphocytic infiltration is very prominent. You can see there other findings. I'll talk about that. So this is important. You can see the scalloping effect. Scalloping effect, if you remember your histology of the thyroid gland, you can see some definitely, but here is very prominent. Excess. Expert can tell that. Okay, this is about hyperthyroidism, thyrotoxicosis, and we talk about Graves' disease in that. Moving on to hypothyroidism. So any structural functional derangement interfering with production of thyroid hormone ends up in hypothyroidism. What is hypothyroidism? Reduced level of T3, T4. And what happens to TSH in hypothyroidism? Students. Come on, I want you to interact.
It will be high.
It will be high, and because of TSH level is high because of
the negative
feedback mechanism. Okay, negative feedback mechanism. Very good. Okay, very good. TSH level we have because of negative feedback mechanism. T3, T4 level is low. Then the pituitary and hypothalamus detect it and produce more TSH. And that's the most important diagnostic findings. So developmental, what are the causes for hypothyroidism? Developmental is congenital defects in the development of thyroid gland. Surgical removal, for example, patient has a Graves disease and they take out the thyroid gland, later become hypothyroid. Radioactive iodine usage can cause hypothyroidism, destruction of gland. External radiation, very common in patients with radiotherapy. Recently, I come across a patient who informed me that initially they had lymphomas, Hodgkin's lymphoma, underwent treatment with radiation, and after a year now he or she is in hypothyroid state. So that is very common because thyroid gland is very sensitive to radiations because it's dividing very fast, functional cells, and sensitive to thyroid gland. So always whenever you are doing x-rays or CT, make sure the thyroid gland is protected. Autoimmune, another important condition called Hashimoto's thyroiditis, where you see hypothyroidism. There in Graves' disease, you see hyper. Iodine deficiency is one of the commonest cause of hypothyroidism you see in clinical practice. May not be in Malaysia because it is usually people who stay away from the sea. Okay, who stay away from the sea source because the source, the fishes and sea salt are good amount of iodine in them. And I remember it's very common in India, especially in the sub-Himalayan regions, where the iodine content in the soil is very low, the nutrition is low. They have to give, there is a huge campaign going on everywhere in the world. WHO recommended this iodinization of the salts. So you can find salt in the supermarkets. You can see there they are added with iodine to keep away hypothyroid state. Yes, now it's low in number. I remember in my childhood, many people have seen with big swollen hypothyroid state goiters, but now less. Drugs, iodoids or amino salicylates can cause that. Secondary pituitary failure or hypothalamic failures can also cause hypothyroidism. So the clinical presentation is well summarized here. You know, the coarse, dry skin, hairs and skin, dry, rough, pale skin, because they are low thyroid hormone. You can compare with the other way. So hair loss, very classic in case of hypothyroidism, especially, you know, one of the early we see them, their eyebrows are missing from the periphery. If I'm not wrong, we see this in two conditions. I remember in my clinical setup, we used to tell differential diagnosis of hair loss of the eyebrows, especially from the periphery, is one is hypothyroidism, another is leprosy. And they use the word something like lionidoid face. If you see the lion, they have hairs more in the centers of the eyebrow than the periphery. So cold intolerance here. So less, the metabolism is less. They will be very sensitive to cold. So, but please don't jump on people who has heat or cold intolerance. You know, people who need aircon, who don't need aircon. This different physiological states also. Here they are more have muscle cramps and frequent muscle aches. Constipation in reverse to diarrhea in case of thyroid. Depression here, they have anxiety in case of hyperthyroidism. Irritability is very often, memory loss, abnormal of menstrual cycles, very common here, hypothyroid. Less common in, that can happen in hyperthyroid, but more common in hypothyroidism. Decreased libido and fatigue, weakness, all are because of low metabolic activities. Weight gain or increased difficulty in losing weight is one of the important to check for thyroid hormones. So females, many times they are subclinicals. You know, Kids also we have to look for in the families. They can be in hypothyroid state. I remember one of my child had that in a subclinical state, no clinical presentation. It is when we screen TSH levels were high, we have to give him some form of replacement thyroid hormone for year or two, then tapered off. But the growth was really good after that. Activity. So one more place you can look for, because childrens are very prone, and especially infant who are born to mothers with hypothyroid state without replacement during pregnancy may end up in a state called cretinism. Cretinism comes from the word Christ. The face looks like a Christ, innocent face, and typical face. They have short eyes and narrow angle, mouth open, wide nose, interocular distance are wide. So all this you can read about cretinism. Basically, they have, if they are not replaced, the kids are not replaced by thyroid hormone, they end up in severe retardations with physical and mental retardation, short stature. They have umbilical hernias because of weakness of the abdominal wall. It's basically maternal iodine deficiency, seen in typical regions where the diet is deficient of iodine. I'm telling you, this incidence has come down now, but at times we can find these things in third world countries because why? Iodine everywhere is added. We call fornification. The word fornification, adding nutrients to your diet. Myxedema, coma, sluggish, cold skin. You can see the facial expression, expressionless face, the edema in the lower limb, dry, coarse skin. When you feel these hypothyroid people, the skin will be cold. Okay, this is about hypothyroidism, and let's see, thyroiditis is acute illness with severe thyroid pain. Thyroiditis can be infectious, very common with bacterial, viral infections. Subacute granulomatous thyroiditis, which is subacute because not clinically significant, little inflammation and thyroid dysfunction. It includes subacute lymphocytic thyroiditis, which is painless. And we have another fibrous thyroiditis we call Riddle's thyroiditis. More important about thyroiditis is Hashimoto's thyroiditis, very common, most common cause of hypothyroidism in an area with sufficient iodine level. Otherwise, most common cause of hypothyroidism is iodine deficiency. So it's an autoimmune destruction of the thyroid gland. So I'll always keep in mind, very easy to correlate. When there is autoimmune, what should be the morphology microscopy? You see lots of lymphocytes. Keep that in mind. Autoimmune destruction, gradual thyroid failure, hypothyroidism. It's painless condition. Painless diffuse enlargement of thyroid gland. So clinically, please remember, whenever there is a pain, you should think of subacute lymphocytic thyroiditis. Morphology may be some similar features. So when painless, diffuse enlargement of thyroid gland, hypothyroid states, think about Hashimoto's. Age group is 45 to 65, more common in females. First described by Hikaru Hashimoto's, a Japanese medical practitioners. So pathogenesis, what happens if thyroid epithelium, breakdown of self-tolerance by autoimmune condition and induced thyroid antibodies to CD3, CD8. That stimulates basically, stimulates CD8 cells and CD4 cells, and that activate macrophages and cytotoxic effect on thyrocytes, thyroid gland follicular epitheliums, and antibody-dependent cell-mediated toxicity happens also. Anti-thyroid antibodies, all this cause destruction of thyroid gland. You can see the patients present diffuse symmetrical enlargement of both the thyroid gland, intact capsule, and well demarcated glands. So you can see a size of the gland well demarcated. Cut surface is pale gray tan, firm gray tan, suggests there is some fibrosis or cellular state and somewhat nodular presentations. Microscopically, very classic to see mononuclear cell infiltration, lymphocytes, plasma cells, this one, dense lymphocytic infiltration with germinal centers, like it looks like a lymph node architecture because of excess. Another important feature is Hurther cells or oxyfolate cells or Ashkenazi cells, epithelium with abundant eosinophilic granulocyte. Hurther cell hyperplasia is seen in this condition. Severe thyroid follicular atrophy. Some thyroid follicles are seen, but you see maximum replaced by immune cells. Fibrosis, then keloid-like fibrosis. That's why the color gray firm. The thyroid parenchyma demonstrate features of chronic lymphocytic thyroiditis. This is what Hurther cells looks like, a characteristic large cells with abundant cytoplasm, polygonal in shape, distinct cell borders, voluminous granular eosinophilic cytoplasm. So large, often hyperchromatic nucleus with prominent nucleoli. Nuclei are red color, prominent. So these are the features of Hurther cells. Next is subacute granular. The features itself, if you ask for clinical presentation, is all hypothyroidism in Hashimoto's thyroiditis. Moving on to subacute granulomatous thyroiditis, which is commonly seen in 40 to 50 years old female. Most likely it is viral infection or post-viral inflammatory process. Most common viruses include Coxsackie virus, mumps, measles, adenoviruses. So there is obviously acute pain in the neck, fever and malaise. That is very classic in the clinical presentation. Enlargement of thyroid gland, which can be unilateral movement. Transient hyperthyroidism followed by hypothyroidism. This is very classic. Initial phase of this state, they will have transient hyperthyroidism. That can also be clinically in Hashimoto's thyroiditis. Initially, they have hyperthyroid state because of the inflammation, because of the destruction of the gland. The high amount of hormone is released in the circulation, and this initially may present with hyperthyroid state. Later, they may have hypothyroid state. So, but here in the recurrence subacute granulomatous thyroiditis, hypothyroid phase is self-limiting, transient. It will be reversed within 6 to 8 weeks. So that's why it's important to differentiate from Hashimoto's, that is permanent. Multinucleated giant cells are very classic to see in this. So basically, when you see there is polymorph nuclear infiltration, that means lymphocyte. Polymorph means it's not about neutrophils here, but they are talking about multiple types of cells. Anyhow, lymphocytic, predominance, plasma cells, macrophages, giant cells, enclosed naked pool. So in center there is multinucleated circular arranged giant cells containing center as fragments of colloid. Because of these modified giant cells, they are called giant cells, are nothing but epithelial modified macrophages. So there's granulomatous thyroiditis is this. What else? It is once again, so subacute granulomatous, but now next is subacute lymphocytic thyroiditis, usually seen in middle-aged females, same age group, but no pain here, silent or usually seen in postpartum conditions, like it can be autoimmune origin. So you will see painless neck mass, features of thyroid hormone excess. Initially, same way, because of inflammation, thyroid toxicosis followed by euthyroid and then hypothyroidism. Mild symmetrical enlargement of gland, histologically lymphocytic infiltrate with plastic germinal centers. So you have to keep this in differential diagnosis of Hashimoto's thyroiditis. Rare forms include the Riedel's thyroiditis, extensive fibrosis. We don't know why it happens, so idiopathic in conditions. Palpation thyroiditis, thyroid inflammation due to mechanical damage to follicles. So you too much palpated. Coming to goiter. Goiter is enlargement of thyroid gland. What is goiter? Enlargement of thyroid gland is a term used for enlarged thyroid gland. Diffuse multinodular goiter. Diffuse and is the most common condition, enlargement of thyroid gland, and it's basically due to impaired synthesis of thyroid hormone. Most common cause is dietary iodine deficiency. So what happens is reduced thyroid hormone, that will why there is diffuse enlargement of thyroid gland and why there is multinodularity enlargement of thyroid gland. So diffuse enlargement of thyroid gland is when there is a consistent low level of thyroid hormone, because there is no example in iodine deficiency. You already know from your physiology that iodine is very important for the synthesis of thyroid hormone. If there is no iodine, like iron is important for synthesis of hemoglobin, no iron because iodine cause iron deficiency anemia. When there is no iodine, there is iodine deficiency lead to thyroid hormone deficiency or reduced production, that lead to negative feedback mechanism of TSH. TSH function is to stimulate follicular cells to produce more hormone, but produce more follicular cells. So follicular cell hyperplasia and hypertrophy happens under the influence of TSH, thyroid stimulating hormone, but functionally they cannot do anything because source is not there, the ingredients of iodine is not there, hence no production of T3, T4, and that use a cyclical phenomena of increased TSH and no T3, T4, and follicular cell is constantly stimulated for results in hyperplasia and hypertrophy, end up in enlargement of thyroid gland. We call it as goiter. So this is the pathogenesis. But what happens further is there is compensatory increase in size, tries to maintain the euthyroid state, but initially, but at the end it is hypothyroid state. Further what happens is because it is enlarged, there is enlarging beyond. Sometimes there is what happens is inside there is injuries, ischemic injuries, and that lead to fibrosis, and that lead to nodularity. So that's end up in multinodular goiter. We'll see that, and there is also cystic changes. So why it happens? It is endemic where there's iodine deficiency. It can happen sporadic with the different reasons. Many times it has been blamed. The contents of our food can lead to goiter, and substance that interfere with thyroid hormone synthesis, which includes excessive calcium, vegetable belonging to like cabbage, cauliflower, and Brussels sprouts. These contain goitrogens that cause goiter and that interfere with thyroid hormone synthesis, and that can lead to multinodular goiters. So microscopically and grossly, first of all, the gross, there is hyperplastic phase diffuse goiter happens, follicle lined by crowded columnar epitheliums, and microscopically they are papillae, same like Graves' disease. If dietary iodine increase or demand increase, involution of epithelium and gland, colloid goiter happens. And cut surface brown, glassy, translucent. What is the picture here? The enlarged thyroid gland. Cut surface, you see ground glassy picture. But what we see microscopically, the follicles are hyperplastic in early stage. During involution, the flattened and cuboidal epithelium. So basically, it is alternate state. What is involution means? If there is hyperplastic phase when there is no iodine, and when sometime they get some dose of iodine, then it will reduce the follicular epithelium, come down and become flattened epithelium and cuboidal epithelium, but colloid content will be high, so colloid is abundant. That's you a enlarged state. So what happens is recurrent episode of hyperplasia and involution. Hyperplasia and involution lead to multinodular goiter, and presence of fibrosis happens there. Multilobulated asymmetric enlargement of gland, massive size, cut surface. When there is multinodular goiter, cut surface, irregular nodules containing variable amount of gelatinous colloid. Regressive changes, fibrosis, calcification, hemorrhage, and cystic change is seen. So microscopically, you see colloid-rich follicle, flattened epithelium in multinodular goiter state. Inactive epithelium, areas of follicular epithelium hyperplasia accompanied by degenerative changes are also seen. So you see, if this is a normal thyroid, here you see enlarged thyroid glands. Plummer syndrome, toxic multinodular goiter. What happened in few patients? in few patients, there is one area of the multinodal goiter become autonomous nodule without any further, they become autonomous, they develop into long-standing goiter, produce hyperthyroidism. So that is called as Plummer syndromes. The condition is not accompanied by infiltrative ophthalmopathy or dermatopathy of Graves' disease, but it is a hyperthyroid state. Coming to the last part of the lecture is thyroid neoplasms. So thyroid nodule is very concerning and very important is whether they are functioning or not. So whenever you come across a patient with thyroid nodule, you have to do a very clear clinical workout, proper history, proper examinations, whether the patient, and by this time you should be aware when it started, how it's, whether it's painful, what are the other clinical presentations. You should know the neck swellings, whether it's thyroid origin or not, which moves with the debilitation, or it's any other condition. Like you have to keep the differential. You would have learned in anatomy the thyroglossal cyst. All those things keep in mind. Think about different condition, inflammatory, goiter, and thyroid neoplasm. So you have to ask every time patient is having male or female, young or old, single nodules or multiple nodules, whether there is history of radiation in head and neck, whether the nodule is cold or hot. This is very interesting. Huh? Cold nodule, hot nodule. Cold nodule, hot nodule is on scan. We do a special test we call thyroid scan using radioactive iodine, and we check for uptake of this radioactive iodine. If the nodule is hot, we'll take the radioactive iodine. That means it's functionally active. It is the source of hyperthyroid state. Cold nodule is functionally not active. They are not taking radioactive iodine, hence it's cold. Somewhere picture should be there. Any picture I have with hot nodule, cold nodule? No. Oh, this is not. Maybe somewhere you can find. So basically that is radioactive iodine scan, which is an important investigation. We'll learn that in clinical years, definitely. So thyroid neoplasm is like most endocrine neoplasm are too worrisome. Principles. One, benign tumors often have stream pleomorphism that confuse us whether it's a malignant, and malignant tumors, some of the malignant tumors may not have pleomorphism that may confuse whether it's benign. So it's very tricky diagnosis of thyroid neoplasm. So careful expert opinion is very important. The benign tumors of thyroid gland, obviously its origin from follicles, and follicular neoplasms of benign nature is called adenomas, and benign usually are solitary painless mass with local symptoms, pressure effects on the neck. They present with hoarseness of voice, difficulty in deglutations, or difficulty in swallowing. So basically the adenomas origin from follicles, epithelium, hence they call follicular adenoma of thyroid. And if they are functional, if they are producing hormones and they are causing a hyperthyroid state or toxic state, they are called toxic adenomas also. That is, hormone producing in a functional adenoma is independent of TSS stimulation from the pituitary. So the morphology of this condition of adenoma is grossly, you see, it's a very classic picture. You see very well capsulated. That's a feature of neoplastic origin, the capsulated follicular adenomas, solitary, spherical, and encapsulated, compress the surrounding thyroid tissues, bulge out when there is cut surface. So it's compactly arranged within the capsule. The color range from gray-white to red-brown depending upon the cellularity. More cellular, red-brown, and more colloid in them. Red-brown is more colloidal and cellularity is gray-white. Area of hemorrhage, fibrosis, calcification, and cystic change is seen in this. Secondary changes, though it's benign. So microscopically, very interestingly, cells arrange uniform follicles. It's basically, if you see this looks like a sheet, but they are round follicles with colloid in them. They are uniform with well-defined cell borders and no much polymorphism. Sometimes you see Hurter cell change, oxophilic change. Hallmark of this adenoma is presence of capsule. This is normal thyroid capsule separating from neoplastic cells. So here you can see gross and microscopic features of follicles in microscopy. Coming to thyroid carcinomas, there are different types of thyroid carcinoma. The most common is papillary carcinoma of thyroid. Then there is follicular carcinoma, there is medullary carcinoma, and there is anaplastic. So each one has their own incidence. The most common is papillary, 75 to 80%. Medullary carcinomas are 5%, does not arise from follicular epithelium, but parafollicular cells, that is C cells, and it is very prone to get into amyloidosis. So that's your entrance questions or multiple choice question. Anaplastic is worst, is highly undifferentiated. So aggressive tumor of anaplasia. Papillary carcinoma, the most common carcinoma of thyroid gland, and very interesting, very clinical and pathological features are very classic. So grossly you see them area of fibrosis and calcification, cystic change and cut surface. You can see some papillary structures. The word itself is telling. So this is the thyroid gland with papillary carcinomas. So, but the most important is the nuclear features of the microscopic. So very fine dispersed chromatin. The nucleus will have a fine dispersed chromatin, optically clear appearance, that ground glass appearance or orphan ani nucleus we talk about, because of the intranuclear inclusions. When we see in the, I tell you, when we see in our practicals, you will see this definitely. So papillary structures are once again crowded cells with dense fibrovascular core with blood vessels in them, which provide nutrition to the neoplastic malignant cells. And there are some bodies at times we can see lymphocytic permeations or infiltrations, and these are very often prone to metastasize to local lymph nodes. So I was talking about the classic nucleus because of nuclear inclusions. You see the nucleus look empty, something like orphan ani. You would have seen this character in your series. So orphan ani nucleus, what we call about this clear ground glass nuclei. So here is also you can find that small some bodies in the center, but try to appreciate the nucleus, empty looking ground glass appearance. So at times you can see growing in the, we also call this specifically, I think on cytology, when you do FNSC of this, you will see the coffee bean growing of these cells, nucleus, sorry. Some bodies with papillary architecture, fibrovascular core, orphan ani nucleus at places here. Is another somoma bodies. So it's calcification, basically degenerative calcification leading to somoma bodies. In case of papillary carcinoma of thyroid, moving on to follicular carcinomas. Follicular carcinoma of the thyroid is more common in female, older age group, no papillary structure, single nodules, well circumscribed, widely infiltrative. The most important is carcinoma. This anywhere, including the difference of follicular adenoma and carcinoma is invasion in carcinoma. So that's very careful diagnosis has to be done because microscopically they compose of uniform cells, the small follicle containing coli, quite same as thyroid gland. Though malignant, they look like normal, dangerous, huh? But you know, these cells are malignant, they can invade. That's why capsular invasion or no capsule is, and there is secondary changes in the gross, you can appreciate. So invasion in the capsule, this is capsule and invasion is the diagnostic. Medullary carcinoma is a neuroendocrine neoplasm derived from C cells or parafollicular cells, calcitonin secreting So obviously calcitonin level can be high. It can act as a tumor marker, a high level of calcitonin, diagnosis of medullary carcinoma of thyroid in a thyroid neoplasms. So may elaborate somatostatin, serotonin, ACTH, and vasoactive intestinal peptide because of the parafollicular cells. And these have a typical clinical presentation. So medullary carcinoma is also what you call commonly associated with amyloidosis, myeloid protein deposition. So they can check on Congo red stain with polarized light that apple green birefringence is diagnostic of amyloidosis. Lastly, anaplastic or undifferentiated carcinoma. So undifferentiated tumors of thyroid epithelium, rapidly enlarging bulky mass, aggressive mortality is 100%. That means that is very aggressive one. Symptoms of compression like dyspnea, dysphagia, hoarseness of voice and cough. In most cases, local invasion and lung metastasis at the time of presentation because of the aggressiveness. So that's it about the theory part. Lecture is done. Any questions, any doubts? So we have discussed about important conditions of thyroid, which includes, we discuss hyperthyroidism and hypothyroidism, the causes and clinical presentation. We discuss about Graves' disease, an important cause for hyperthyroidism. We discuss about thyroiditis, in that specifically Hashimoto's thyroiditis, subacute granulomatous thyroiditis, or lymphocytic thyroiditis, and some other forms have been explained. Then we have talked about multinodular goiter or diffuse goiter with multinodularity, and the causes, the clinical features, and the morphology. Morphologies is very important in most of the conditions we are describing here. So you very favorite questions in exams, specifically the morphology of either Graves' disease, Hashimoto's, multinodular goiter, and in tumors specifically papillary carcinoma of thyroid. And adenomas are very important to keep in mind because of their functionality, the hyperthyroid state. The toxic adenomas specifically will give more clinical presentations of hyperthyroid, but you have to think of a tumor in the neck. And most important, investigations. We have not dealt here in detail, but you have to keep in mind approach toward the diagnosis is clinical, history taking and examination, and then the tests, the blood tests, specifically the TSH level, T3, T4 levels, and the radiological investigation. Not only we do scans, ultrasound or CT scan, but also we do thyroid scans using radioactive isotopes 131 and look for the functionality of the mass or the swellings to decide whether they need surgeries or whether they need treatments. And most important is the diagnosis, clinical diagnosis and the final diagnosis. So at times we usually the diagnosis is by gold standard, you can tell, is FNACs. You can get many information before surgery. Definitely after surgery, you can do the biopsy and look for this morphological changes. But very often thyroid is just below the skin in the neck, and we do fine needle aspiration cytology, and very helpful in the pre-operative diagnosis, confirming conditions and to decide what treatment is needed. So this is about the thyroid disorders. So I'll stop the recording.